Hello, my name is Sharon Best. I'm a physician assistant. Welcome to tonight's lecture. We have two distinct audience viewers tonight. We have My Catholic Doctors and APP to APP virtual lectures. I am a provider at My Catholic Doctor. I specialize in NaPro technology and infertility. Additionally, I do see women in person in a small private OBGYN practice outside of Philadelphia. So tonight's lecture is Polycystic Ovary Syndrome and NaPro technology. The aim of the lecture will be to compare mainstream medicine literature and the international guidelines for the diagnosis and treatment of PCOS to NaPro technology protocols. And I am hoping to convince you by the end of the lecture that NaPro protocols are superior. So what is NaPro technology? NaPro stands for Natural Procreative Technology. It's the medical and surgical practice and where a provider undergoes a very unique training, and we learn to interpret the biomarkers of a woman's menstrual cycle. NaPro technology was created by Dr. Thomas Hilgers, who was at the time a faculty at Creighton University. He initially created the Creighton Model System, which is a standardized system of charting a woman's menstrual cycle. After receiving thousands of charts, and after a decade, patterns started to emerge that he noticed. So taking those into consideration, NaPro technology was born. So it's important to know that we treat many different common gynecological conditions in NaPro. This is a website I created that is for education for patients as well as for NaPro providers. So when I do post this lecture on APP to APP website, you will have a PDF file, and these are hot links. You can click directly into any of the links to read about the conditions and see how we treat them with NaPro. So objectives for tonight, we're going to look at some general information. We're going to look at diagnosis, and again, I'll compare mainstream med with NaPro. We'll look at medical management, surgical management, and I'll summarize the differences between them at this point. There will be some additional slides that I won't cover in detail, but you will have them for reading and for learning. We'll look at some red flag labs, and I'll also talk about many clinical pearls. So some general information. The history of PCOS is really interesting. Two OBGYNs who lived in Chicago in the 1930s, Dr. Stein and Leventhal, noticed that a number of their women had a constellation of similar symptoms: amenorrhea, oligoamenorrhea, high blood pressure, hirsutism, infertility, and obesity. And what they did is took 7 women and they did a bilateral wedge resection. So this is an ovary with a pie-shaped wedge being excised. So they did report in a paper that the 7 patients who underwent this bilateral ovarian wedge resection were completely restored in physiological function. So this was the paper published in 1935. So it was the first paper published on PCOS. And impressively, this paper is still cited today, and it's 85 years later, and that's quite impressive for a publication. So now we'll look at prevalence and etiology. So PCOS is the most common hormonal problem in women of reproductive age. It affects about 9 to 13%, and some experts believe as high as 21. We know that there's an increased prevalence as much as 20 to 40% in patients who have a first-degree relative, so a mom or a sister that's affected. And in spite of all these years of studying PCOS, the etiology really remains unclear. We know it's a very complex disorder, and it has multi-factors contributing to the etiology, such as genetics, nutrition, lifestyle, and maybe even environmental factors. So some risk factors. So you'll see that NaPro technology will be compared to mainstream medicine side by side. I'll use blue font for NaPro and green font for mainstream med. This is table 43.2, taken from Dr. Hilger's book, which we affectionately refer to as the Big Black Book. So he cites that high cholesterol, diabetes, high blood pressure, cardiovascular disease, thrombosis, endometrial cancer, ovarian cancer, and breast cancer are all risk factors. I start off thrombosis and breast cancer because noting that our women are treated with a birth control pill, very early on when this diagnosis is made. And we do know that the pill is thrombogenic, and we also know that it does have an increased risk for women who are younger of breast cancer. Mainstream Med, I took this wonderful slide from Up to Date, and I like to think of this slide as helpful when taking our medical history. So obviously we know to ask about oligo and ovulatory cycles. We know to look for obesity and diabetes as being associated and a higher risk. We may not know to ask about premature adrenarche. So adrenarche per se means awakening of the adrenal glands. This is diagnosed as premature if a young girl, 8 or under, develops adult-like pubic hair, axillary hair, body odor, as well as adult-like acne. This is due to a precipitous rise in a chemical or a hormone coming out of the adrenal glands called DHEAS. So we wouldn't know, most patients wouldn't give us this information, so we should know to ask about it. There is a higher association of premature adrenarche with patients with PCOS. We talked about the first degree relatives. Ethnicity, Mexican American and Australian Aborigines are more likely to have this diagnosis. And interestingly, use of or past use of a drug called valproate, also known as Depakote or Depakine, has a higher association of women with this disease. We use this medicine quite often in neurology to control seizures, and we also use it in psychiatry for mood disorders. So diagnostic criteria. Before we move forward, I'm going to introduce you to a document called the International Evidence-Based Guidelines for the Assessment and Management of Polycystic Ovary Syndrome. These are the guidelines published in 2018, where over 35,000 expert professionals from around the world got together to review over 250 articles and give their expert opinion. It will be cited more heavily than most, although I have cited about almost 50 publications for this lecture that are on the end slides. This was headed by Professor Helena Teed, who's a PhD researcher from Monash University. So when you see Teed referenced or 3 as my citation, you'll know we're referencing the guidelines. So here's our first side-by-side diagnostic criteria for PCOS. According to Dr. Hilgers, this patient should have oligo or anovulatory cycles, clinical evidence of hyperandrogenism, and biochemical evidence of hyperandrogenism, as well as polycystic ovaries diagnosed either by ultrasound or laparoscopy. Now, Mainstream Med has the same 3 criteria. However, Mainstream Med prefers something called the Rotterdam criteria, where we really only need 2 of 3 of these to make a diagnosis. Mainstream Med is also a little more specific compared to Dr. Hilgers. So for instance, in order to meet the criterion for oligo or anovulation, Dr. Hilgers requires menstrual cycles greater than 35 days or less than 8 cycles per year. Whereas in whereas in Mainstream Med, if the patient has only been menstruating for 1 to 3 years, they may have cycles less than 21 days or greater than 45. If they've been menstruating greater than 3 years, cycles less than 21 or greater than 35, or less than 8 a year. And if they've been menstruating greater than 1 year, they can have cycles 90 days apart. And in reality, even though the table in the book doesn't say this, when we see this, we also will make a diagnosis of oligo or anovulation in NaPro. So clinical and biochemical signs of hyperandrogenism are exactly the same. Clinically, we're going to look for hirsutism, acne, and alopecia. Interestingly, 60 to 90% of the patients with PCOS will have this. And polycystic ovaries may be a little more detailed and may require us a little bit higher threshold to meet this criterion for Mainstream Med. They require that a single ovary has greater than 20 follicles within it, or the ovaries are greater than 10 centimeters in volume. So in summary, Mainstream Med and NaPro are very similar with regard to their diagnostic evaluation or the criteria we need to meet to make this diagnosis. Here's a clinical pearl. How do we measure ovarian volume? So the radiology report on the ultrasound will give us 3 dimensions of the ovary. we're going to take those three dimensions and we're going to multiply them together to get a sum. And then we're going to multiply that sum by 0.52. So patient A has a left ovary of 5.8 mils and a right ovary of 6.84 mils. And you wonder, why do we multiply this sum and almost cut it in half? We do that because the ovary is an ellipsoid shape, and multiplying these three dimensions is going to give us cubic centimeters squared. So if we put this ovary into a cube, we see we have a lot of additional space outside that we have to account for. So for that reason, we're going to multiply the sum by 0.52. So as you can see, a comparison in patient B, we have a left ovary of 12.15 mils, a right ovary of 10.58. So she meets the criteria for polycystic ovaries. So it's important to mention that we do have four phenotypes, A, B, C, and D. A is easy to remember because it includes the patient meets all three of the criteria: oligoid ovulation, hyperandrogenism, and polycystic ovaries. Whereas I think D is easy to remember because this patient has no hyperandrogenism, and that's going to be relatively unusual. Remember, we mentioned 60 to 90% of individuals will have hyperandrogenism. So B and C, the patients have two, and a third criterion is not there. So what's clinical hyperandrogenism? So I think it would be easy for most of us to diagnose this young lady with hirsutism if she came in our office. However, we do have a standardized system that's good to know about. It's called the Fuhrman-Galloway scoring system. It was developed in 1961, where we use 9 body regions and we score them from 0 to 4 for hair growth. So according to TEED, or the guidelines, a score of 4 to 6 using the Fuhrman-Galloway score would indicate hirsutism. And interestingly, there was an article published by the Endocrine Society in which they talked about the wide variation in ethnicity with this scoring system. So they broke this down and recommended that for a US or UK Black or white woman, they really should have a score equal to or greater than 8 in order to make a diagnosis of hirsutism. Mediterranean, Hispanic, and Middle Eastern, greater than 9 or 10. South American, greater or equal to 6. Han Chinese, greater or equal to 2. Southern Chinese, greater than 7. So it's not easy to get these high scores. You'll see, we'll look on the next slide. But before we do, I want to mention that when we're doing this scoring system, we really have to be only evaluating coarse hair that if left alone will grow longer than 1 centimeter. And a clinical pearl is the way that we can ask this so we don't miss it is say to the women, do you pluck, shave, or tweeze hair from, and then we can mention some of those 9 areas. So you would be surprised how many women say yes to this answer. So generally, what we would expect to see is women that come into the office that look something like this. So this is the Fuhrman-Galloway scoring system. Okay, so you see we have 9 body regions: upper lip, chin, chest, abdomen, pubic area, upper arms, upper thighs, upper back, and sacral area in the back. Scores are 1 to 4. So generally, we'll see women that look more like this in our office. So as you can see, she has some coarse type hair on her chin. It extends into her neck. So she would be scored a 2. This patient would be scored a 3. She has lower abdominal hair, and you would put her right about here on the Fuhrman-Galloway scoring system. Whereas this patient would have a score of 2. This is a sacral area. Remember, we're not talking about vellus hair, but we want to be careful too not to give a diagnosis of hirsutism too easily. So this is alopecia. Women don't bald in the same distribution as men. And again, we're not really looking for an areata. So we're looking for a woman's balding to make the diagnosis of hyperandrogenism. So we want to look at the part of her head, and here is a grade 1 and 2 and 3. Now with acne, most of our women are going to have acne because of their age. We see women that are adolescents to through adulthood. So acne is not unusual to persist into 30s. So we don't want to make a diagnosis of hyperandrogenism when we see just simple whiteheads and blackheads in a normal T distribution, forehead, chin, and nose. However, if we see more prominent acne, so this is a classic distribution for PCOS. If we should ask about acne on chest and back, because that's going to be more than just a simple hormonal acne. And then, of course, we want to look for pustules and nodules, which are pustules greater than 1 centimeter in diameter. So we can also grade our acne with grade 1, 2, or 3. Acanthosis nigricans is another skin condition that we should be looking for when we do our exam. It's not associated with hyperandrogenism, but it is associated with PCOS because it is associated with chronically high insulin. So it's a thickened hyperpigmentation of the skin that is often found in the nape of the neck, under the arm, below the breasts, and also sometimes on the elbows and knuckles. A clinical pearl here is if you diagnose acanthosis nigricans in one of your patients, you should really refer to derm because this is associated oftentimes with occult malignancies, particularly GI cancers. So what's biochemical hyperandrogenism? So here's where we're going to take a little bit more of our deep dive. So in order to do that, we have to look back at our undergrad anatomy. So we know that we have adrenal glands that sit on the kidney. They're divided into 2 layers, a cortex and an inner medulla. So the cortex itself is divided into 3 layers, an outer zona glomerulosa, a middle zona fasciculata, and a deep zona reticularis. The glomerulosa synthesizes and secretes mineralocorticoids. The primary one is aldosterone, and we recognize aldosterone as being related to our blood pressure. Zona fasciculata produces glucocorticoids, with the most common one being cortisol, and the zona reticularis is the one responsible for producing the androgens that we're going to be looking at. So the zona reticularis produces DHEA, DHEAS, the same thing with a sulfide bond, androstenedione, testosterone, and dihydrotestosterone. So we only go check in the blood for the 3 that are in red. And the reason is because DHEA without the sulfide bond is very transient, only lasts between 15 and 38 minutes in the blood. Whereas the half-life of DHEAS is 7 to 22 hours. So we're going to get much higher numbers of this compared to this. Dihydrotestosterone is an intracellular androgen, so we're not checking for that in the blood. So biochemical hyperandrogenism by definition is high androgens in the blood. It's important to know which ones are coming from where and in what percentages. So DHEAS is produced primarily by the adrenal glands and only 5% by the ovaries. Androstenedione is 60% ovaries, 35 adrenals, and 5 from peripheral tissue conversion. Now, testosterone is secreted primarily by the ovaries at 60% and only 5% by the adrenals. So interestingly, when we see high testosterone and normal DHEAS in our polycystic ovary patient, we can assume that her disease is being driven by her ovaries. And when we see high DHEAS, whereas testosterone is maybe normal, we can know that her PCOS is being driven by the adrenals. If we're driven by the ovaries, we would expect the ovaries to be large, whereas if driven by the adrenals, they may not. So we look at perhaps treating with bilateral ovarian wedge resections. So someone with a polycystic ovary syndrome driven by the adrenals wouldn't be of any assistance or help to her. So moving forward, testosterone is 99% bound to a transport plasma protein called sex hormone binding globulin. So just like all transport proteins, this one is going to be produced in the liver. So if we have liver problems, we may have a lower production of sex hormone binding globulin. If you have a lower production of a transport protein, when 99% is typically bound, you're going to have more free testosterone. And this is the testosterone that is actually active. So I usually do pull baseline liver and kidney functions. I do a CMP just to take a look at that. Additionally, if we have high sex hormone binding globulin, which actually can happen with the use of the birth control pill, we should have a more fictitiously low free testosterone. So we should keep that in mind so we don't miss a diagnosis. So a clinical pearl is, for this reason, to be able to put all the puzzle pieces together, I do suggest ordering both a total testosterone, free testosterone, and sex hormone binding globulin and putting those pieces together. So some clinical pearls. As mentioned, testosterone levels are not reliable in women on the pill, and that's because of the increase in the sex hormone binding globulin. Also, DHEAS is very varied by age. So this is a table that I took from the LabCorp website. Looking at the high end, so the ages go from 12 to 75. So just looking at the upper limit of DHEAS, we see that we're 328 as a teenager. We're going to go up until we're about 30 years old, and then we're going to start to decline in this neurohormone. Mainstream medicine has a lot of interesting findings with the literature with regard to DHEAS and PCOS, and we'll talk about that in a few slides. So androstenedione is the immediate precursor of testosterone. And remember, it's about 60% in the ovaries, 35% in the adrenals. But a way we can connect some puzzle pieces is oftentimes our PCOS patients will have high luteinizing hormone. We generally see luteinizing hormone is higher than FSH, which is what we call a reversed ratio. So when luteinizing hormone is high, we know that it triggers an increased androstenedione. And since that's a precursor, we'll have an increased testosterone. So increased LH equals increased androstenedione equals increased testosterone. And we're going to be favoring a little bit more of the ovarian-driven polycystic ovary when we see this. So now look a little bit closer at some steroidogenesis. Okay, so what we're looking at is we're looking at the adrenal cortex, and we're looking at some of the biosynthesis. So this area right here is representing the zona glomerulosa, with aldosterone being the final mineralocorticoid. This area here is representing the zona fasciculata, with cortisol being the final glucocorticosteroid. And this area right here is representing the zona reticularis, and the androgens are put in red boxes for you. So please note that these pink boxes are enzymes. So in order for cholesterol to become pregnenolone, we have to have this enzyme to catalyze the reaction. And this enzyme to catalyze pregnenolone to progesterone. I start off the enzyme 21-hydroxylase because we may recognize that as a 21-hydroxylase deficiency being a marker for what we call congenital adrenal hyperplasia. So if the adrenal glands are very large or hyperplastic, we might expect that more androgens will be synthesized from them. So what's going to happen if this enzyme is deficient? So we have two types of congenital adrenal hyperplasia. One is called the classic, which is typically diagnosed in the neonatal period and can be very fatal. The other one that we'll see in our office is called a non-classic. It's diagnosed a little bit later in adolescence or adulthood. And in the non-classic type, we have a deficiency, and it isn't quite as severe as the classic. But if this enzyme is knocked out, let's look what happens to these reactions. We start with cholesterol. We can easily make pregnenolone and then progesterone, but then we can't move forward. So this patient will have a low aldosterone, probably a low blood pressure, and low aldosterone will go with high potassium. So one of the reasons to be pulling that CMP, and again, we can put puzzle pieces together. So what happens if the reaction can't move forward? It's forced in this direction. And so what ends up building up but 17-OHP? So this is one of the labs that we're going to draw to tell us that the patient may have non-classic congenital adrenal hyperplasia. So when this is high, we do have to have a confirmatory test, which is a adrenocorticotropic hormone stimulation test. So now let's take a look at what happens when these reactions are then pushed in this direction, which will happen if all of the reactions below here are inhibited. So we'll have more reactions going in this direction, and we end up with a higher amount of androgens being formed in the blood. And the pearl is 40% of patients with non-classic adrenal hyperplasia actually have polycystic ovaries on ultrasound. So some red flag labs. So this is a table for total testosterone in women, again, taken from the LabCorp site. So we can see that testosterone will change by age, but the upper limit remains relatively similar. So this is an easy one to memorize, that we could memorize these parameters at 10 to 70. A 150 testosterone level should really give us some concern about more like an ovarian tumor or an adrenal tumor. Another clinical pearl is if you see a postmenopausal woman who presents with a new onset or very severe worsening of her hirsutism or hyperandrogenism, either clinically or biochemically, then you should also suspect an ovarian or adrenal tumor. So as mentioned, these numbers are much higher, but after menopause, we can see how they do go much lower. Again, so if we see these red flag labs, we should be ordering a CT of the abdomen and pelvis with contrast to look for those tumors. So we also have to rule out PCOS mimics. Okay, so we've already talked about the non-classic adrenal hyperplasia at length. So here's a pearl. When we order 17-hydroxyprogesterone, we should specify that that lab should be drawn very early in the morning, in close proximity to awakening, preferably before 8 a.m., which is my note to the lab and to the patient. It's also important to know that 17-OHP will decrease as the day progresses. So now let's take a look at thyroid dysfunction. So a clinical pearl is NaPro, and also fertility specialists in mainstream medicine do recommend that we optimize TSH or optimize thyroid function in our patients who are struggling with fertility. So in NaPro, we usually pull a much more extensive panel for thyroid function: TSH, free T4, total T3. The reverse T3 is in red because I'm going to discuss that. We do automatically pull the antibodies, anti-TPO and anti-thyroglobulin. So why is my reverse T3 in red? What I've noticed is it's multiple patients come back and their thyroid hormones are just perfect. They're actually optimized for fertility. And the only thing that's off is the reverse T3 is a little bit high. And then when we calculate a ratio, which we look for, a total T3 to reverse T3 ratio, when we calculate that, we see that the ratio is low. So some NaPro providers say as long as that ratio is 6 or greater, they're comfortable. Other NaPro providers want that ratio to be 10, which I think is pretty hard to get to. So I have a hard time telling a woman when only her reverse T3 is abnormal and her T3 to reverse T3 ratio that she has a dysfunction of her thyroid, because I don't really believe there is really a dysfunction. Interestingly, the half-life of reverse T3 is very quick. It's 3 hours long. So, and we know that this reverse T3 is increased secondary to an increase in cortisol. So as you know, as the day goes on, we secrete cortisol at different times depending on our stress levels. So I can see how this level, if we checked a woman at one time in the day, she was very relaxed, she might have a much lower reverse T3. If we checked her later in the day after a very stressful event, might be much higher. So again, that's one of the reasons why mainstream med doesn't pull that lab. And so I've decided not to draw the reverse T3 anymore for my NaPro patients. Now, clinical pearl is you may want to check for iodine levels. So I have never in 20 years of being a PA seen an iodine deficient goiter or iodine deficient induced hypothyroidism in the US. I have seen it in third world countries on mission trips. So interestingly, now that our salt that most of us are using is sea salt, it's completely not iodized. And for that reason, we're now starting to see low iodine. And so let's look at prolactin. So a clinical pearl is, we do order prolactin because high prolactin can interfere with periods and fertility. So the pearl is, the patient should be fasting. We should tell them no sexual intercourse, nipple stimulation, or exercise for 48 hours prior to the draw. It's because all of these things can increase prolactin fictitiously. So a pearl is, what are some of the differential diagnoses? The first thing I think of with a high prolactin is I go and look at some medications. So atypical antipsychotics are going to decrease dopamine. Dopamine in the hypothalamus will naturally inhibit the release of prolactin releasing hormone. So if we have low dopamine, we're going to take away that normal healthy inhibition of prolactin, and we're going to have high prolactin. So look for these atypical antipsychotics. They're very common. They used to be used more for psychotic syndromes. They're used very much for even a more significant anxiety now these days. Also some antiemetics, anti-high blood pressure pills, opioids, and I put medical marijuana here because I recently did have a patient who had a prolactin that was about 78. And she repeated that, and then it was still high. She asked me if we could repeat it one more time. It was totally normal. And then she disclosed that she had totally stopped her medical marijuana. And I do believe that that was probably what was increasing her prolactin. Medical marijuana is being prescribed like water. We don't have a lot of research behind it. We really don't know a lot of the side effects. So I generally recommend to my patients that you don't take it because we really don't know what it's doing, especially in the central nervous system. So the full laboratory workup side by side for mainstream med, they order a free testosterone level. And if that's abnormal, then they'll go ahead and draw the total androstenedione and DHEAS. They will draw the FSH, LH, and estradiol, 17-OHP, prolactin. They'll do a TSH, and if the TSH is abnormal, it will reflex to free T4. So in their defense, why do they do so much less labs than us? The reason is because the research is showing that there's a lack of clarity as to which androgens to measure for PCOS, what assays to use, and what are actually the normal ranges. Some of the studies are even showing when they do normal controls in PCOS and they look at that DHEAS, some of them are overlapping where the normal controls are having as high as the PCOS or vice versa. So that's one of the reasons why they're not pulling all of these additional labs. And also there's a cost for the high quality assays. So for us in NaPro, we're known to do a more thorough workup. So as long as my patients can afford it, I generally follow a regimen that looks something like this. I order what I call cycle day 3, FSH, LH, and E2. Of course, we're going to be looking at that FSH to LH ratio to see if it's reversed to help make a diagnosis of PCOS. Her estrogen may be either normal or high. And also, this is a great lab that I pull for most of my workups. And the reason is because it can tell me a lot. Say I had FSH very high and E2 very low, that can tell me a premature ovarian failure. Say I had FSH very low, LH very low, E2 very low, that can tell me a functional hypothalamic amenorrhea. All of these can be contributing to her infertility. So prolactin, again, we're going to ask for this lab to be fasting, no nipple stimulation, no sex or exercise, rigorous exercise within 48 hours. 17-OHP, draw that in early morning, preferably no later than 8 a.m. And then I do my health labs. CBC, CMP, 25-OH vitamin D, and lipids if the patient's BMI is over 25 or if they're nearing 40 years old. So again, these are the labs I'll pull first because they can all be done at once in the morning without a meal. I wait till the second visit. I bring them back to review the labs, and I also get them started charting the first visit. It's better to do in person. I give them a lot of education. Then I order the second set of labs, which is the thyroid panel. Again, I'll do the TSH, free T4, and perhaps a total T3. I will be omitting the reverse T3. I do the antibodies, again, if their insurance is good and there isn't a problem with payment. I asked for these to be non-fasting because there is some literature to show that when the patient has fasted, these labs are fictitiously high. I then draw the androgen profile. Obviously, it would be indicated for a suspicion of PCOS, and it may be indicated for some of the other conditions I'm working up. And we discussed testosterone, free and total, DHEAS, androstenedione, and sex hormone binding globulin. Then I tell them, please continue to chart. We're going to be then moving to the next level. So they come back to me in another month. Hopefully they have 2 months of charting by then. And then I will pull what we call the progesterone and estrogen panel for post-peak. And I will also look at what we call peri-ovulatory, so estrogen around ovulation. And we do those panels like this. The patient has learned to recognize a peak day, which is going to be a day that's very close to her ovulation. And she's going to do that on the Crichton model charting. We will draw the progesterone and estrogen on P plus 3, so the third day after the peak, P plus 3, 5, 7, 9, and 11. Estrogen as well as progesterone, and then we can plot them against norms. For peri-ovulatory, I'll ask her to estimate her next peak day and go to the lab on P minus 6, so 6 days before that, and then every other day until peak. And then once she hits her peak, we're going to do one more lab draw on P plus 2. And then we'll plot them to norms for peri-ovulatory estrogen. P plus 7, so an estrogen and a progesterone on 7th day after peak is often drawn to evaluate our management and ongoing care. So now there are some additional screening labs that are recommended by both NaPro and Mainstream Med. If we suspect polycystic ovary syndrome, the patient is overweight, we might want to draw that lipid profile. And also we want to check for hyperinsulin. So a hyperinsulinemia is very common in patients with PCOS. So it's a pre-diabetic stage. So generally hemoglobin A1C is going to miss this. So mainstream medicine recommends a 2-hour oral glucose tolerance test where the woman comes in fasting, glucose is taken, she's given 75 grams of glucose to drink, and then she waits around for 2 hours and comes back and has the lab drawn again. So because this is labor intensive, Mainstream Med allows for an alternative of a fasting glucose plus a hemoglobin A1C to be evaluated. Now in NaPro, the recommendations are to do the 2-hour glucose tolerance test. And in addition to insulin fasting, along with that first glucose draw that's fasting, and then an insulin drawn again 2 hours later after the glucose load. So if we understand hyperinsulinemia, this is an amazing test that should be quite specific with regard to our diagnosis. So there is another a test that is used as a screening test for hyperinsulinemia. It's called the HOMA-IR, where a fasting glucose and insulin is multiplied and divided by 22.5. This is called the homeostasis model assessment of insulin resistance. It's been very well studied. There's over 500 trials documented. It has been well accepted as a screening test, but most experts agree you shouldn't be making a diagnosis of insulin resistant using the HOMA-IR. And the reason is because the sensitivity and specificity that have shown on this lab have widely varied, and cutoff recommendations widely vary, especially among different ethnic groups. So for instance, there was such a variation in the sensitivity and specificity that I didn't put anything on the slide. But one that I remember was the test was 96% sensitive and showing up about 76% specific. So if you understand those terms, that means that 96% of the time you're going to get, yes, this person has it, but only 76% of the time is that they truly have it. So if you look at those numbers, there's about 25, 26% of the time you're going to get a false positive result using the HOMA-IR. So it really is great to be used as a screening. And then if they come up as a positive screen, go ahead and do the 2-hour oral glucose tolerance test. So AMH is a hormone that is released exclusively by the granulosa cells in the follicle. So the follicle is a fluid-filled sac within which the ovary, or within which the egg, the follicle is within the ovary, and an egg is going to mature within the follicle during the phase that the woman is prior to ovulation. So there's two types of cells that make up that follicle: thecal cells and granulosa cells. So the granulosa cells are secreting anti-Mullin hormone. It's a great marker for infertility and primary ovarian failure. We would expect that when the follicles are not responding, this would be very low. And we would expect that someone with a lot of follicles, like PCOS, would have a high AMH. So it's a very logical expectation. However, there has been a lot of studies to try to use this to diagnose a PCOS, but they've been, again, inconclusive with what should be the exact level of AMH that we would be looking for to make that diagnosis. So we have to talk a little bit about biotin interference. So in 2020, the American Academy of Clinical Chemistry released a document called the Clinical Document of Biotin Interference with Laboratory Tests. So its name tells you exactly what it was presenting. I have prescribed biotin at 5 milligrams for many patients over the years, especially for telogen effluvium, so their hair loss. It supposedly improves skin and nails. And I had no idea that biotin interferes with all of these labs. And these are labs that obviously were pulling a lot for NaPro. So it interferes with prolactin, THS, and other thyroid function tests, parathyroid hormone, which we may pull for some of our osteoporosis patients, especially if they have a very low vitamin D before we start treating them, adrenocorticotropic hormone, and testosterone. So we should be very vigilant in one, asking our patients, are you taking this? Because it's a vitamin, so they may not feel it's important to disclose. And also, if they are taking biotin, we should ask them to stop at 48 hours prior to their lab testing. Let's take a look at ultrasound imaging next. We only have a few slides on this. So NaPro looks at some external morphological signs. They notice that the ovary are more spherical than ovoid, so they're more round than ellipsoid shape. Also, the number, they look at echoless regions. That's referring to the follicles that we see that are generally distributed in the peripheral region of the ovary. This is one ovary ultrasound. These are all follicles remaining in that ovary. Interestingly, he mentioned an increased echogenicity in the ovarian stroma. So the stroma is going to be the connective tissue between the parenchyma. So we can see high intensity here, bright white, which is what Dr. Hilders was referring to. So mainstream medicine no longer requires an ultrasound to make the diagnosis, because remember, the Rotterdam criteria only requires 2 of the 3 criteria, and they don't, if they have the oligo or anovulatory cycles and they have the hyperandrogenism, we don't even need to go get the ultrasound. So they also say that no ultrasound imaging should be done for anyone who is less than 8 years post their first period. So for women who have not been menstruating for at least 8 or 9 years, they say don't even do the ultrasound. And again, they do specify that a single ovary should have greater than 20 follicles and a volume should be greater than 10 mils in order to meet this criterion. So this is polycystic ovaries taken from Thomas Hilders' books. You can see how large the ovaries are. You can see they're sort of a whitish surface and they almost look like speckled eggs. This is a view of a laparoscopy. So generally, oftentimes this view, the ovaries might be a little bit hard to find, tucked between the tubes. Here's your uterus, here's your fallopian tubes on either side. But these ovaries just jump out at you. You don't even have to, they're not hidden at all, so we know they're quite large. So let's look at medical management. So in green, oral contraceptive pills, combined oral contraceptive pills are the first-line treatment for PCOS in mainstream med. In NaPro, we do progesterone replacement, and in reality, progesterone is given in some infertility clinics as well. We both use metformin and myo-inositol. Really, NAC is exclusive to NaPro, which is N-acetylcysteine. We both use cervical mucus enhancers. So infertility and mainstream med would use some of these, as would we. Anti-androgen medications, really only used in mainstream med now, even though they are cited in Dr. Hilger's book. Most of the NaPro doctors that I've spoken to are not using them. I choose not to use them because we believe that the risks outweigh the benefits. And then we're going to talk about naltrexone. So according to the guidelines, combined oral contraceptive pills are first-line treatment. They cite that they regulate the menstrual period, but we know that they really suppress it and induce what we call a withdrawal bleed. They certainly would decrease the risk of endometrial hyperplasia and endometrial cancer, because if you're going to suppress normal ovulation, you're not going to build up the lining of the uterus. They increase sex hormone binding globulin, which is true, and thus they will decrease the free testosterone level. They do recommend that oral contraceptions with 35 milligrams of estrogen be avoided, particularly because of the thrombogenic event. Okay, so here's absolute contraindications quoted in the guidelines. So interestingly, I think many women may have some of these, at least the migraine with aura, and sometimes some more minor complications, even though these are really significant complications in pregnancy. But we know that oftentimes women are put on the pill very quickly without a deep investigation into some of these contraindications. So I Googled the package insert for Yaz. I've never prescribed the birth control pill, but I do recommend to my patients that go ahead and Google the package insert, name of the drug, and take a look at what it says. Sometimes if I think the drug is more of a risk than to their benefit, I try to let them educate themselves. So these are all the risks that were listed on the Yaz insert. So there is tons of thrombogenic events, tons of different types of tumors. They're pretty easy for everyone to look up. I do want to spend a few minutes on NaPro's teaching on contraception. So we don't give the birth control pill to treat most of our diseases. One, because we don't feel that it's good medicine. We really believe that, particularly in the case of the reproductive GYN issues, that giving the pill just completely suppresses ovulation, and it can cause a lot of negative sequelae. We look at this as doing a Band-Aid approach when we just stop the reproductive cycle. So many of us in NaPro are comfortable saying this. Some of us may be a little less comfortable or maybe a little less knowledgeable about the spiritual and emotional impact of the contraceptive pill. So I'm going by John Paul II, our former Pope's teaching. He taught a lot about love and sexuality. And he wrote a few encyclicals, one called Love and Responsibility. And the second, he gave a lot of talks that ended up being compiled into a big, thick book called Theology of the Body. So what he explained and what he taught the church teaches is that when a woman uses contraception, she actually diminishes the act of sexual intercourse to become purely a physical act, when in reality, this act was made by God to be much deeper and to have emotional and spiritual components. We do believe in the Catholic Church that the act of intercourse is actually a symbolic gesture or an outward physical sign of the expression of true authentic love between a man and a woman. And when it is diminished, the woman feels that on a very deep level. Authentic love is very selfless and sacrificial. I recommend all my patients read this book. It's John Paul II's Love and Responsibility encyclical, made very, very simple by Edward Sri. The book explains it much better than I can explain it. So let's talk a little bit about progesterone replacement. So first thing we need to know is mainstream medicine and NaPro both agree that we should not be using an LH monitor in patients with PCOS. An LH monitor is a clear blue is the most common. So it looks like this. The woman will remove the cap and she'll urinate on the stick, and it's going to sense the level of luteinizing hormone and estrogen in her urine. And it is supposed to be indicative of ovulation. So we know that it's inaccurate with ovulation with women with PCOS for a number of reasons. First of all, the Clear Blue website itself will tell you it is. So I have this link on my website. I'm going to pop into it now. This is from the Clear Blue website, but it's very hard to find. It's a PDF that I found, and I tell my patients to scroll way to the bottom of the PDF and look at where it says further information. And I'll make this big for you. And it basically says you'll receive misleading results if you have polycystic ovary syndrome. It also tells you that you will have misleading results if you're on any type of ovulation induction medicines. So they mention Clomid, I believe, in here, but we use Clomid and letrozole. So we know that those medications, in addition to some antibiotics that we use, particularly the family of tetracyclines, that they will all make this LH monitor result inaccurate. So I think that's a really important information to give to your patients. So the link again is on my Queen of Heart website. You can use that and pop right into it. Now, what does NaPro say about the LH monitor? They let you know that, of course, women with PCOS have higher levels of LH at baseline, so that would be one reason why it would be inaccurate. We also make diagnoses of something called luteinized unruptured follicles, or LUFs. So LUFs may have lower high levels of LH. The studies are actually mixed. However, we do know that luteinizing unruptured follicles will secrete progesterone, and that will mimic ovulation oftentimes. So we do give the patient a false sense of ovulation. LH monitors are inaccurate again with women on fertility drugs. We do give HCG injections, and so does fertility clinics. And again, we give the ovulation inductors, Clomid and letrozole, and also tetracycline antibiotics. Doxy is used for STDs, and Doxy and Mino are both used for acne, which we may have see our patients on with PCOS. And one last caveat is urinary LH is going to rise 24 hours after blood LH. And we know that we have a small window of fertility for the female. So if she's struggling with infertility, you might do a further injustice by having her miss the window if she's checking for ovulation and having timed sexual intercourse according to a Clear Blue monitor. So let's look at some Crichton model system biomarkers. This is a Crichton model system chart. You can see the period bleed, some dry days. Generally, we have a mucus buildup, which is when the egg is starting to develop, the follicle is developing around it, the follicle is secreting estrogen, and the estrogen is causing the cervical mucus. This woman here identified a peak day right here. So ovulation is believed to occur within 72 hours in 99% of women before or after the peak day. So these are her post-peak days, 1, 2, and 3. We know that these are days of fertility. And then she starts days of infertility. So we do look at the pattern of the bleeding. And the pattern should be a crescendo, decrescendo, or decrescendo pattern to be a true period bleed. So crescendo, moderate to heavy, heavy, moderate, light. So here's a crescendo, decrescendo. The other biomarkers we look at are the full cycle length. Remember, we mentioned how that 35-day cycle would be criteria for the PCOS. We look for the confident identification of the peak day. We count the length of the post-peak phase, which begins on first day after peak and ends to the last day before the period. So that post-peak phase being short often tells us low progesterone. We calculate something called a mucus cycle score when using her mucus buildup, and we look for the unusual bleeding patterns, which could be bleeding between periods. It could be bleeds that are not really periods. It could be tail end brown bleeding, which is brown bleeding at the end of the period. It could be premenstrual brown bleeding. So here's a PCOS chart. Okay, so this woman obviously has very long cycles. She is beyond 35. This is 38. So her cycle was 38 days in length. She had intermittent bleeding, so that's unusual bleeding. If I made this big for you, you would see that she has a very dry mucus. Her mucus cycle score is low. We can't even calculate a pre and post-peak phases because she can't identify a peak day because she's really not ovulating. So what we're seeing is we're seeing non-ovulatory cycles. These are not period bleeds. They don't follow the crescendo, decrescendo, or decrescendo pattern. Rather, she has lots of very light bleeding and brown blood. So this is telling us she probably has low progesterone. And so what we're seeing overall is anovulatory cycles. We're seeing breakthrough bleeding, which is really when her uterine lining is just continuously exposed to estrogen. It's going to build thicker and thicker. It doesn't have progesterone being released because she's not ovulating. And the progesterone is what causes her to have a period. So she has a low progesterone, she has high estrogen, she's anovulatory, she's having breakthrough bleeding, she has a PCOS. So we do recommend progesterone replacement. So what we do is we try to trigger a period by giving her progesterone injections or progesterone by mouth. And the next slide is going to explain that to you in detail. But I do want to mention that oftentimes they may ovulate, they may not ovulate, or in different cycles. So the endometrium, again, being exposed to chronic estrogen without the opposition of progesterone causes that endometrial hyperplasia, which is a risk for endometrial cancer. So it is really important that we give this woman some treatment. So NaPro protocols are to give 100 milligrams injections on day 18, 21, 24 of her cycle, and that's to hopefully induce a period. And also some NaPro physicians prefer to give the progesterone by mouth, and we would do that daily for 10 days. So we'd start on day 18 and go to day 27, and hopefully that would bring on a menstrual cycle. Once the menstrual cycle ensues and we can identify a peak day, we're going to then change those doses to 100 or 200 milligram injections on P plus 4, 7, and 10, or if we're using the by mouth, 100 to 200 milligrams PO on P plus 3 through 12. And we're going to continue this regimen and see if we can get her to ovulate. We can also give the progesterone per vagina. This is a chart where we see the patient had a very long cycle. We can see she bled here, and the progesterone injections at 100 milligrams were given on this day, and then 72 hours apart and 72 hours apart. So we induced a period here, and then we started on day 18, 21, and 24 with the 100 milligram injections. So let's take a look at metformin versus myoinositol. Again, both are used by both. So according to the mainstream literature, actually, this is a dose that we give in NaPro. So this is a mainstream literature and NaPro slide. So the dose we give in NaPro is 2,000 milligrams of myoinositol and 50 milligrams of dikairoinositol. So they taken together, they're going to have the best effect according to the literature. We tell the patient to take this first thing in the morning and then take again with your nighttime meal. So the concern here is this is expensive. So to get a bottle of 120 pills of 2,000 megs / 50 megs, the dose to get that in is 4 pills. So the patient would have to take 8 pills a day. And I've looked at the prices a little bit. They run from $25 to $45 a bottle. So $50 a month is a lot of money. They do come where you can take 2 pills at a time, but those bottles are more expensive, about $60 a month. So for someone who has financial hardship, we have to be careful not to be prescribing this. We can prescribe just myoinositol. It's much cheaper. So that would be my recommendation for a patient to start with who has PCOS with high insulin and high androgen levels. According to the guidelines, they say inositol in any form is really only experimental. There was a Cochrane systematic review, a meta-analysis, which found no difference in any of the endpoints for inositol versus placebo. And their endpoints were many, which makes me sort of wonder. So BMI, ovulation, testosterone, triglycerides, cholesterol, fasting glucose, fasting insulin. So Tang et al., however, published an article in 2018 that did say that myoinositol actually appeared to improve ovulation rate and menstrual cycles in women with PCOS. And I loved this one. This was a very large multi-center trial done in Germany, 254 gynecologists, 3,602 patients with PCOS were given myoinositol 2000 plus the 200 micrograms of folic acid. So not D-chiro, but this was matched with folic acid. They were given it twice a day for only 3 months. It resulted in 545 pregnancies. And what was more impressive is the total testosterone went from an average of 96.6 to 43.3. That's an impressive decline in testosterone. And progesterone, and I'm sorry, I don't have the day of this draw, went from an average of 2.1 to 12.3. So I know in the post-peak phase, 12.3 isn't a bad number. We look for somewhere around 15 for P plus 7. So according to Dr. Hilgers, inositol is going to increase the action of insulin, improve ovulatory function, decrease serum androgens, decrease BP, and decrease triglycerides. So we do advocate this, and I think the medical literature actually is reasonable in giving weight for that use. So metformin, some NaPro providers don't want to use metformin, but others agree that it's important to use it if when we try the myoinositol, we still can't get the insulin and sugar into the ranges that we need it. So we know that we need to not have our patients have very high blood sugar. We need to control their diabetes. So Dr. Hilgers agrees with doing that. He says women should be properly treated, and if drugs are needed. The PCOS guidelines do recommend metformin be considered in women with a BMI greater than 25 kilograms. So let's look at a little bit about NAC, cervical mucus enhancers, and anti-androgen medications. So NAC is N-acetylcysteine. It is a mucolytic. So just like as if you took NAC to break up congestion in your chest with a cold, it's also going to break up the mucus and make it more watery and more stretchy and more fertile. So NAC is actually quite good for improving mucus cycle scores. Dr. Hilgers did believe that his research showed that NAC improved insulin sensitivity in patients with PCOS. The guidelines, there is no mention of NAC, but I did find a study published in 2018 that did feel NAC reduced hirsutism as well as improved fasting blood glucose sugar or fasting blood sugar. So let's look at some of the cervical mucus enhancers. So some of our women have very limited mucus or dry mucus. It's very difficult to get pregnant, although I have seen one patient with completely dry cycles recently become pregnant. So God can make babies when he wants. But oftentimes we do need good mucus. So we can enhance that mucus quite effectively by using vitamin B6, a sustained release, 500 milligrams once a day. We generally recommend that for 60 days. And then after 60 days, we reduce to 100 milligrams and do that for another 6 months. So also, if this is not enough to increase the mucus, we can add on 2 other drugs. I usually would add them on one at a time. So guaifenesin, again, is an over-the-counter mucolytic known as Mucinex. We'd give that the regular doses, but we would time it right around ovulation. So we'd give 1,200 milligrams twice daily on the 4th day prior to the expected peak day and continue daily through P plus 2. Amoxicillin, we would give the same days. We would give a 500 milligram tab 3 times a day. So anti-androgen medications. So spironolactone is quite well known to be given to women with PCOS to try to reduce the hirsutism. It's given at a doses of 50 to 100 milligrams twice daily, and it is recommended in some mainstream literature. According to the guidelines, they recommend that if the patient is on this, it's mandatory that they're on oral contraception. So they agree with trying spironolactone if they've tried and the hirsutism is still quite out of control on the combined oral contraceptive pill. The reason they want the mandatory contraception is because this can be very dangerous to a male baby. It can under-virilize, so it can allow his sex organs not to develop the way they're supposed to. So because of these risks, generally most of the NaPro providers that I've spoken to, including myself, choose not to use the spironolactone because, again, we feel that the risks outweigh the benefits. In Dr. Hilger's big book, he does actually advocate spironolactone and also mentions cimetidine and finasteride. This is a category X in pregnancy, so this would be off my table. And cimetidine, I'm not too sure about, but I'm not sure if the data is quite convincing on using that either. So naltrexone is interesting. So naltrexone is an opioid antagonist. It goes into the mu opioid receptors, and it's used in mainstream med quite frequently for people with addictions. It's believed to help when we feel this receptor. It helps reduce their cravings. So we've been using naltrexone for many years to treat PMS at a high dose, what we call high dose, the regular dose, 50 milligrams. We also use what we call low dose naltrexone at 4 milligrams to treat autoimmune diseases such as Hashimoto's. So we have tons of years of using this very safely and effectively for these two. In 2017, we had a study that stated opioids have been found to be elevated and may stimulate insulin secretion in the pancreas. And they found that naltrexone inhibited actually this insulin secretion in response to a glucose challenge. Another study in 2001 with 127 women noted there was high beta endorphins in the pancreas and related with high insulin levels, high beta endorphins with a high PMI. So very interesting, more mainstream studies, 2002 and 2001, 50 milligrams of naltrexone in women with PCOS. Yes, it was super small, only 10, significantly reduced BMI, menstrual cyclicity was improved, free testosterone, androstenedione, and THEAS were all decreased, fasting glucose to insulin ratio was improved. Another study stating the 50 milligrams used for 8 weeks improved the insulin response from the oral glucose tolerance test. The international guidelines don't mention naltrexone at all. So some of the side effects, if you're going to be using this, either for PMS or low dose, or maybe trying it in some PCOS patients, are vivid dreams, nausea, headache, dry mouth. But our patients very rarely experience any of these because we always start, regardless of the dose that is our endpoint, we always start extremely low. And all of this is on my website under the PMS page if you're interested in seeing that dosing regimen. So there is a warning that we need to give to our patients, that we want to tell them that they are really not to drink alcohol at all if they can. And if they do, it's extremely sparingly because you can get quite sick on naltrexone drinking alcohol. That's the purpose. It's supposed to stop the addict from wanting this drug. Also, if you're going to have a surgery, you're going to be needing opioids to help with your pain. We often give the opioids you see listed here post-surgically, and that is a good use of these opioids. And we don't want the receptors filled so that our patients will be experiencing pain. So surgical management for PCOS. Mainstream med recommends ovarian drilling. NaPro recommends the ovarian wedge resection. So the ovarian wedge resection, as we looked at, is when a wedge-shaped piece is taken out of the ovaries. NaPro uses a wonderful near adhesion technique where they will oppose the sides, they will invert the edges, they'll suture underneath, they'll use suture that is not adhesive producing. This particular surgery, as mentioned, was introduced in 1935, but fell out of favor when IVF came in, and also because it was producing adhesions, which any surgical procedure in the pelvic area will produce. But we have minimized those adhesions, and we have wonderful studies to show that we can do that well. My website has a laparoscopy page. You can take a look and see how our surgeries are non-adhesive producing. I give a little more detail there. Mainstream medicine drills the ovary, as you can see, the large polycystic ovary with drill holes. We don't have as good as outcome with ovarian drilling. That's pretty much accepted in the mainstream medicine literature. Here was some literature on the bilateral ovarian wedge resection that actually stated that it works quite well. 150 patients showed a return of regular menses that lasted for 25 years. So that was some literature that was in the guidelines. Barbarari didn't like it. He's a a local endocrinologist. He believes that the pelvic adhesions outweigh, and that using the ovulatory induction drugs, Clomid and Letrozole, and of course IVF, outweigh this surgery. We do not agree. We believe that the bilateral ovarian wedge resection is amazing. And again, we do see regular cycles returning in 3 months after surgery in 90% of these patients. We see a reduction in androgens and improvement in insulin resistance. And it really helps the patient to be able to comply with many of the lifestyle changes and the weight reduction that we're really trying to push and help them with, because these are first-line treatments, they're natural and they're effective. So here's a chart before and after a wedge resection. So we have a very long cycle, as we can see. After the wedge resection, she returned to a normal cycle. So a summary now for what we've gone over is the similarities are, we're very similar with regard to the criteria we want for diagnosis. We're similar in the workup, but NaPro is going to do a much more extensive and thorough workup. And again, I would encourage my colleagues to be cognizant of our patients' financial situations. The differences are that NaPro preserves the woman's natural reproductive health. We don't put a Band-Aid by using the oral contraceptive pills. We strongly believe that we are giving a greater service to our patients to unmask the problem, take them off the pill, have them chart, look at the natural, look at what's happening with them naturally, and then replace hormones naturally. So progesterone would be replaced only in the post-peak phase. Sometimes we need to give estrogen, such as a case of hypothalamic amenorrhea. And we generally will simulate a normal and healthy cycle with bioidentical hormones. We do not use the synthetic hormones that are often used in the birth control pill that have a lot of the negative side effects. The bioidentical hormones that we use do not have those risks or side effects. We use charting, again, to pick up those biomarkers to help us to diagnose the underlying cause and guide our treatment. We often use inexpensive over-the-counter reproposed medications, and all of our NaPro physicians are actually here because they love God and they want to serve their patients selflessly. So I'm just going to briefly go over a few slides: associated medical conditions and additional screenings, and of course, lifestyle changes and weight management. These are the associated conditions we've talked about a lot. I want to highlight depression, anxiety, poor body image, and eating disorders. I have been profoundly moved by the psychological effects of the PCOS patients that I have seen so far. It is much more profound and difficult for them than I had realized. So the guidelines, lifestyle and weight management, everybody likes that. So go for that. I usually refer all my patients to a dietitian. Again, screen for the psychological issues. I really like cognitive behavioral therapy, and screen for cardiovascular risks. Okay, we know they're associated, especially if we have patients 40 and above, and screen for apnea. Apnea has a lot of negative sequelae. Many of these patients are obese. It's very easy to refer them for a sleep study. So I'm going to end here.